afternoon, all. May I start? Good afternoon, all. Uh, Presenting the paper on the topic Association of Vertical Cup Disc Ratio and Disc Damage Likelihood Scale with OCT RNFL in 100 eyes of primary open angle glaucoma. All over the world, the prevalence of glaucoma is rising and is expected to affect 101.8 million people by 2040. And most of the cases, it is asymptomatic. So, early diagnosis, treatment, and follow up is required to reduce the ocular morbidity. And for the evaluation and monitoring of the glaucoma, optic nerve head assessment, visual field test, intraocular pressure assessment, these are the most commonly used. And optic nerve head assessment, it mainly depends only on the clinician, whereas visual field test depends upon patient cooperation experience, and intraocular pressure measurement has day-to-day variations and fluctuations. So, cup disc ratio is the most commonly used method of assessing optic disc clinically, and it was introduced by Armali in 1967. It is the ratio of the diameter of cup to the disc, and it has got high inter-observer variability and low reproducibility. And since it does not consider size, small disc with small vertical cup disc ratio are more likely to be classified as normal, whether they actually have glaucoma or not, whereas large disc likely to have larger cup disc ratio may have normal NRR, are more likely to be classified as glaucomatous. And this damage likelihood scale, it's a newly introduced scale by Spieth and colleagues, and it estimates optic nerve damage by considering disc size, and it classifies disc as small, medium, and large, and it focuses on the neuroretinal rim and helps in documenting the area of greatest thinning, and it has got high inter-observer reproducibility. This is the table showing DDLS nomogram. Here it considers the disc size and classifies into small, medium, and large. It considers the location of the cup and width of the neuroretinal rim, and if at all it is absent, the extent of absence also included, and it divides the glaucomatous disc stage into 8 stages and helps in the documenting progression of the disease. And aim of our study is to compare the correlation of vertical cup disc ratio and disc damage likelihood scale with OCT RNFL in 100 eyes of primary open angle glaucoma patients. And this is a cross-sectional study conducted in a tertiary care center in North Kerala. And study population include all newly diagnosed and follow-up cases of primary open angle glaucoma patients who have met our eligibility criteria, and sample size were taken as 100 from the formula for linear correlation of two quantitative variables. And exclusion criteria were the following. Study procedure: all patients underwent detailed anterior segment examination. Cup disc ratio, OCT RNFL scan were also taken. Disc diameter is calculated with walk 90D lens with correction factor of 1.3 in slit lamp. Then disc was classified into small, medium, large based on size. DDLS stage and score is calculated based on DDLS nomogram. Data was entered and analyzed, and results: mean age was 58 plus or minus 11.35 years, and 55% were females, 45% were males. And of the 100 eyes examined, majority of 66 eyes had medium sized disc, and of the 100 eyes examined, more than 93 eyes has got cupping of more than 0.6. And DDLS stage, 52 eyes come under category of at risk, 44 eyes come under category of glaucoma damage, and 4 eyes come under category of glaucoma disability. Now, correlation values. After correlation, we have got a moderate negative significant correlation between CDR and RNFL inferior of minus 0.560, whereas with RNFL superior, minus 0.464, and with DDLS, moderate negative significant correlation of minus 0.580 with RNFL inferior and minus 0.570 with RNFL superior. And on comparing DDLS with RNFL inferior has got highest correlation value, and CDR with RNFL superior has got least correlation value, although it is significant. And these are the values obtained in similar studies. Values were comparable with our study. Now, conclusion: strength of correlation with OCT RNFL is more for DDLS than cup disc ratio. So, in the early diagnosis of glaucoma, disc damage likelihood scale will be more helpful than the conventional vertical cup disc ratio method, and superior diagnostic ability of DDLS scale may be due to combination of both disc size measurement and neuroretinal rim width assessment. Thank you.
Thank you very much. That was very nicely presented. Can you just explain to us why you went to DDLS instead of, say, one of the newer technologies like OCT?
Because DDLS is cost effective and relatively simple. In most of the centers could not afford high, and patients also could not afford high end imaging due to cost. So DDLS could be helpful in, since it has got high correlation with structural OCT RNFL. We can correlate and may help in early diagnosis.
Thank you.
Thank you, sir.
Very good presentation. I have one question. You said few of your patients were at risk. How do you define in your study at risk?
Based on DDLS nomogram, we can classify uh, according to yes, at risk, and those risks coming under DDLS category of 1 and 2 were categorized as at risk till they were diagnosed as glaucoma. They were diagnosed as glaucoma and started on treatment, but while I take that patients in my study, they come under at risk category. Yes. Mm. Uh, Same for same patient. Uh, there can be overlap. Yes. Thank you, ma'am.
Respected judges, teachers, and all my dear friends, a very warm good afternoon to one and all. Today I'll be standing here to present a case series of micropulse transcranial diode laser cyclophotocoagulation in patients with iridocorneal endothelial syndrome. As you all know, ICE syndrome is characterized by the abnormal proliferation of the corneal endothelium, and it's characterized by corneal edema, iris atrophy, and secondary angle closure glaucoma. And the glaucoma is often refractory, requiring multiple surgical interventions. And medical therapy is usually unsuccessful in more than 50% of the cases. And also the managing long-term success even with augmented trabeculectomy or glaucoma drainage device is also pending. So we opted for a ciliary body destruction procedure. We have the continuous way with so many side effects, and hence we opted for the micropulse, which was a new kit at the town, which was explained to have less side effects. And also when we looked in the literature, there were no studies exclusively for micropulse done in ICE syndromes, and hence we opted for micropulse in our ICE patients. And our aim was to evaluate the efficacy and safety of micropulse in patients with iridocorneal endothelial syndrome and to understand their clinical profile. It was a retrospective analysis of a consecutive case series. The medical records of 3 IC patients were analyzed, and the epidemiological factors and the number of anti-glaucoma medications pre and post laser and the detailed glaucoma evaluation findings were recorded. The first case was a 36-year-old female with best corrected visual acuity of 6/18, a progressive iris atrophy with a 0.9 cup with intraocular pressure of 46 on 3 anti-glaucoma medications. And the second case was a 47-year-old female with progressive iris atrophy, a best corrected visual acuity of 6/12, and a 0.9 cup with intraocular pressure of 22 on 4 anti-glaucoma medications. And the third patient was a 13-year-old female with Chandler's syndrome with best corrected visual acuity of 3/60, 0.9 cup, and the intraocular pressure was 42 on 3 anti-glaucoma medications. And the cyclogesis glaucoma iridex machine was used in its micropulse treatment mode at a power of 2000 milliwatt power with 80 seconds per hemisphere, and the duty cycle was 31.3. It was given in the sweeping motion, the superior and the inferior quadrant, avoiding the 3 o'clock and the 9 o'clock areas. And all the patients post-laser received topical prednisolone, the atropine, estosolamin 500 milligram for 3 days, systemic analgesics, and I was advised to continue the previous anti-glaucoma medications. And the follow-up was done at 1 week, first, second, third, and sixth month. The significant visual impairment, more than 2 lines loss, hypertonia, and thighs were considered as major complications. Anterior segment inflammation and transient visual acuity deterioration were considered as minor complications. And the post-operative, the best corrected visual acuity slit lamp evaluation findings and intraocular pressure were recorded. And intraocular pressure of 6 to 21 millimeter mercury or reduction of IOP by 20% at 6 months were considered as treatment success. The inability to meet the criteria, the above criteria, or the need of retreatment more than 3 times, or the need of an incision glaucoma surgery were considered as treatment failure. The results, all of the cases were unilateral. It was the middle-aged women which were the ones affected. And the progressive iris atrophy patients present with defective vision and pain was associated with Chandler syndrome. And all the 3 patients, the other eye showed narrow angle for which the laser iridotomy was done. Hence, we should not forget to see the other eye of these patients. And all the 3 patients also had advanced glaucomatous changes in the affected eye at the time of presentation. The mean pre-laser IOP was 40 plus or minus 15.87 millimeter mercury. At 1 week, we had a 67.5% reduction of intraocular pressure. But by 3 months, IOP again spiked back to 34, and it remained high at 6 months also. The number of anti-glaucoma medications actually was adjusted at 1 month follow-up, but again, about 3 months again, it came back to the previous anti-glaucoma medications. We could see that the IOP dip was there at 1 week, and it was maintained for about 1 month, but after 1 month again, the IOP spiked back. There were no major complications. There were mild transient post-operative inflammation was there in all the 3 cases, with the 1-line vision loss was seen in 1 patient. 1 patient was retreated at 3 months, but the IOP remained high after the repeat treatment after 2 months. And the discussion, actually we could not see studies where micropulse was given exclusively in eye syndromes, and hence this was the first case series which was done. But we could see several studies of micropulse in refractory glaucoma, and in a study conducted by Emmanuel et al., even though they showed a reduction of 53%, there was no standardized protocol used in that study, and the mean duration also was more in that study. In a study conducted by Suisi et al., it was also done in refractory glaucoma. The pre-laser IOP was lesser than compared with us, and they had a 35% reduction was seen at 6 months and also at 1 year. In the study conducted by Preda et al., the 41% reduction was maintained at 6, 12, and 18 months, but the number of retreatments were more in this study. The limitations were we could not proceed with micropulse in these eyes patients due to the poor response of these patients, and hence the number was less. So the conclusion is always look the other eye in these eyes patients to rule out for angle closure. And micropulse per se is not the definitive treatment of refractory glaucoma secondary to eyes, or it may help in decreasing the medication burden meanwhile preparing for the definitive incision surgery. These are my references. Thank you. Not the Bundy ear, it was the older probe. The revised probe was used at more power, and the duration is less, 50 seconds and all the revised probe. But we used the old probe, it was done for 80 seconds per hemisphere. Uniform distribution, the shape of the energy delivery. Okay. Okay. Only 1 patient actually. Yeah. No, we didn't attempt. Actually, they were advised this implant surgery. Thank you.
Hang on a minute. So my question was, what did you do for the other 2? You proceeded with surgery.
Actually, they were advised as a valve surgery, actually.
And did they have the surgery and they do it?
We have just advised them.
Okay.
Actually, I was not the surgeon.
Yeah. So my thing about it was it's a good treatment to get the pressure under control for a little while you plan the next stage. It's obviously not the treatment for
Yes, sir.
this.
Yes, sir.
So what sort of implant did you advise?
Ahmed
these
valve.
Maybe I don't know if people are using the tall tube.
I mean, I don't know. I have not also that yet. Fall implant.
Yeah, the
You're
tall.
using the yeah.
Because it has got a big advantage to the other tubes in that the tube is smaller. These chambers look seriously shallow.
Okay, sir.
So yeah.
Thank you.
Good afternoon to all. My presentation is on walking the tightrope, management of raised IOP in pediatric. You just excuse me.
Please stop the timer now.
So sorry. Management of raised IOP in pediatric non-infectious uveitis. The aim, it is that combination of pediatric uveitis and childhood glaucoma presents a unique challenge. It is potentially sight-threatening with paucity of long-term outcomes. So the aim was to evaluate long-term functional outcomes in pediatric non-infectious uveitis complicated by significant IOP rise. It was a retrospective observational study and included all patients less than 16 years of age with non-infective uveitis, followed up over a period more than 1 year. And EMR data was accessed regarding systemic diagnosis, ocular findings, and outcomes. The diagnostic criteria we followed were that significant IOP rise is IOP more than 21 millimeters of mercury on more than 3 occasions, with or without glaucomatous disc and field changes. Steroid-induced glaucoma by IOP more than 21 or change more than 6 millimeter from baseline on more than 2 occasions after starting steroid therapy, and no other cause or evidence or with no other cause of raised IOP and evidence of reduced IOP with reduction of topical steroid use. Criteria for overall success was final IOP less than 21 millimeter mercury or decrease in IOP more than 5 millimeter with less than 2 topical medications, and failure was requiring more than 2 topical medications or above 21 millimeters of mercury. 58 eyes of 33 children were included. You can see that the mean age at presentation was 8.4 plus minus 1, and male to female distribution was nearly same. Laterality 8 unilateral, 25 bilateral. The mean time lapse between uveitis and glaucoma treatment was 8.4 plus minus 6, and mean follow-up period was about 5 years. Mean follow-up after glaucoma diagnosis was about 4.9 years, and best corrected visual acuity at presentation and at final follow-up at the point of the study was were maintaining good visual acuity at presentation as well as later on. The anatomical site of the uveitis, anterior uveitis, was the most common, followed by panuveitis, and the commonest condition was juvenile idiopathic arthritis. The most common mechanism of IOP rise was steroid-induced, and which was in 38 eyes, angle closure synechial in 4 eyes, and uveitic open-angle glaucoma in 16 eyes. The mean IOP at the time of presentation of the patient was 17.83, and mean IOP at diagnosis was 28.68, which was significantly reduced during the follow-up period. The time lapse of uveitis diagnosis to development of IOP rise, the mean duration was 8.38 plus minus 6.2 months. In the steroid-induced subset also, the mean time was little less, but it was not statistically significantly different from the other. Management of the uveitis, all 58 eyes were on topical steroids in the beginning, while 32 needed oral steroids. On final follow-up, patient distribution on basis of the immunomodulatory therapy where only 6 patients were on steroids, while most of them were on other immunosuppressive drugs, methotrexate plus MMF, methotrexate, MMF, and adalimumab, and also methotrexate plus adalimumab in 2 patients. IOP control of 48 eyes, 58 eyes, 46 eyes were successfully managed by medical management. And at final follow-up, 33 eyes achieved IOP control without any topical AGM. 32 of the above 33 eyes belong to the steroid-induced group. So they all reduced with just topical medication and reduction and stoppage of the steroids. And surgical management was needed in 12 eyes of 9 patients. 5 eyes underwent glaucoma filtering surgery with MMC. 5 eyes combined glaucoma filtering surgery and cataract. And both eyes of 1 patient underwent laser cyclophotocoagulation. In children who underwent surgical intervention, the number of AGMs reduced from 2.34 to 1.26 at final follow-up. And surgical procedures other than the glaucoma filtering was 1 eye underwent cataract surgery, and both eyes of the same patient underwent intravitreal dexamethasone implant. In 30 patients, we found favorable outcome, and treatment failure by our definition was seen in 6 eyes of 3 patients. Other ocular complications seen were cataract, band-shaped keratopathy, posterior synechia, macular edema, disc edema, and cyclitic membrane. So the key to balance good IOP control and inflammation control is the key here, and that is by walking the tightrope. And one thing that we found that in our study, 3 eyes developed IOP rise even after 5 years after initial diagnosis. So long-term follow-up later on also these patients can develop raised IOP. Timely initiation and maintenance therapy, most of them were able to maintain a good visual acuity. In our number of patients who required surgical intervention were less compared to other studies, and the reason is the immunomodulatory therapy was initiated earlier itself that reduced both steroid-induced glaucoma and inflammatory glaucoma. In other studies, when we compare, we have very similar incidence of JIA, 36.4%, and eyes that underwent glaucoma surgery, however, is less compared to all the other studies. So my take-home message is that timely diagnosis of uveitis, aggressive control with immunomodulation can help reduce the incidence of steroid-induced glaucoma and generally IOP rise in these children and give good results. Thank you.
If I may ask you, you said surgical intervention. You could tell me like is surgical intervention very more for steroid-induced glaucoma patients or
No, no, steroids. The ones that did not require surgical intervention were 34 eyes, and 33 of them were steroid induced. So, I think 1 patient underwent surgical intervention along with cataract surgery, and the others, all the angle closure ones are the ones who had who needed filtering surgery. And one of the inflammatory glaucomas went on to be very bad and had needed laser cyclophotocoagulation.
Can I ask you what made you go for filtering surgery in the form of trabeclectomy?
With mitomycin C
Mitomycin
instead of a shunt surgery. To be honest with you, because our glaucoma surgeon is, we have a single glaucoma surgeon and he is not very comfortable with shunt surgery. Thank you.
Good morning. My study is a comparative study on the changes in photopic negative response and pattern electroretinogram waveforms in established glaucoma, glaucoma suspects, and normal subjects. As we all know, standard automated perimetry detects changes only after the 30 to 40% of retinal ganglion cell loss, and it is also influenced by patient inattention, fatigue, and lack of understanding. So electroretinography is a minimally invasive, direct objective assessment of retinal function, and PRG and PHNR are electrophysiological markers of the retinal ganglion cell function. So our aim was to compare PHNR and PRG regarding their sensitivity and specificity to detect early glaucoma and its ability to detect the severity of the disease. So we got the ethical clearance, and then we included 42 established glaucoma cases with disc and field changes, and they were graded into mild, moderate, severe according to the HEDOPS classification, and 42 glaucoma suspect with suspicious disc or IOP more than 20, and 42 age-matched normal with normal disc and fields were included. Of that, 2 subjects from the suspect and 2 from established were excluded because of the errors in recording. Exclusion criteria include visual acuity less than 618, patients with poor fixation, and ocular conditions other than glaucoma like the retinal condition which can affect the recording, and patients with dense cataract. So PHNR is performed with Roland Grant's field, blue on white background in a dilated pupil, and PRG was done with an undilated pupil. It took around 15 minutes, and the electrodes were placed on the cornea, and reference blue electrode at the lateral canthus and the ground electrode at the forehead. The PHNR is a slow negative potential that occurs after the positive B wave. Actually, there are 2 negative waves, and the second one, which is deeper, is taken as the PHNR. And the PRG was recorded both for 8-degree and 16-degree checker size, and the PRG ratio was calculated by amplitude to smaller check size by amplitude to larger check size. So the data was analyzed, and we found that the amplitude showed a significant difference in the established case when compared to normal and suspect, which are statistically significant. And also, the PRG did not show a statistical difference between the established case and the normal and suspect. And when we PHNR amplitude also showed a statistically significant decrease in the established group when compared to normal and subject. And then we went on to compare the waves according to the severity of the glaucoma. And we found more severe the disease, the decrease was more. The amplitude and the PHNR also showed a decreased amplitude in more severe disease, whereas the PRG ratio did not have any statistically significant difference. We went on to look at the correlation. There was a weak positive correlation between the PHNR amplitude in both the checker size 8 and 16, but there was no statistical correlation between the PHNR amplitude and the PRG ratio. And when we looked for the ROC curve, the PHNR amplitude was a good predictor of glaucoma, whereas PRG ratio was an unsatisfactory predictor of glaucoma. And we went on to look for the ROC curve for predicting glaucoma suspects. Again here PHNR was a good predictor, but then again here the sensitivity was only 76.3% with specificity of 50.6 and AOC curve of 0.619. So similar study was done by Suresh Vishwanathan et al., who studied only on PHNR, and he also found that it was decreased in the glaucoma patients, and the decrease was more when the disease was more severe. And he concluded that there's a role of potential role PHNR in early detection and possibly in monitoring the progression of the glaucoma damage. And there was a study which suggested that PRG ratio also has significantly reduced, but we didn't find a correlation there. And there's various studies where the ROC curve was 0.9 and 0.86, but ours could match only the North et al. Study where the AOC curve was 0.78. So we concluded that overall the PRG N95 amplitude and the PHR amplitude are useful tools to detect early glaucoma changes and to detect the severity of the glaucoma, and of the two, PHNR performed better. The limitation was the cost involved, the technical training involved, and PHNR required pupillary dilatation, where PRG requires a clear media, dense cataract we cannot do. And these are my acknowledgements. These are my references. Thank you.
What made you go for this?
Actually, I wanted to see the glaucoma suspect. We always are in a dilemma, whether it is a glaucoma, the fields, then the OCT came, still we were in dilemma. Could this bring out something new where we could confidently say this glaucoma suspect is a glaucoma? But again, this AUC curve for that factor was not Very good, it's just satisfactory. That was the main idea of doing this.
Kind of a non-contact procedure with any of these.
They've actually compared the OCT and fields along with this. That we couldn't do. Yeah, yeah. So we needed ethical clearance for all that because we're using a. Hmm. The basic difficulty was to get them trained in that because they're more into all this using in the retinal disease. They didn't have idea of glaucoma. So we had to sit and have discussions, long discussions. That was the basic difficulty which I faced actually.
Particularly very different.
Hmm. But the interpretation part was a little bit.
Interpretation is,
Hmm.
I see a ERG pattern, I don't have a clue as to what the hell is going on, to be fair. So it is difficult and you need very specialized people for that. More importantly, it's not very practical in
Yeah.
and you can't stick it, all right, you can put a corneal electrode on a for, new patient, whatever, probably was never good.
No, there were electrodes which we could, non-invasive, which we could keep in the temporal part also.
Corneal
But,
electrode is cruel in someone,
Yeah.
if you put them on
Yeah.
3 drops for 6
So
months.
we use that for uncooperative patient. We use the electrode, which is non-touching with that. What is a disposable? It was a bit more costlier. Mhm.
Good presentation.
Thank you.
Good afternoon, respected judges, dear teachers, and my dear friends. Today, I'm going to present my paper on cognition evaluation in normal tension glaucoma using Montreal Cognitive Assessment Questionnaire. Normal tension glaucoma is an exception in the glaucoma family where the major risk factor of an increase in intraocular pressure is missing. If not an increase in IOP, then what are the other risk factors? There are many pathophysiologies being proposed, of which a neurodegenerative mechanism due to impaired CSF mechanics dynamics brings the normal tension glaucoma closer to other neurodegenerative disorders. Cognitive impairment is the hallmark of neurodegenerative diseases, and this study was done to find out any potential association between normal tension glaucoma and cognitive impairment. Our primary objective was to compare the prevalence and severity of cognitive impairment between individuals with normal tension glaucoma to a control group. Secondary objectives were to assess the specific cognitive domain affected in individuals with normal tension glaucoma and to find any association between risk factors for NTG and cognitive impairment. It was an observational cross-sectional study done at a tertiary eye care hospital in Kerala. We had 25 NTG patients and 25 age, gender, and education status matched controls with normal IOP without glaucomatous nerve head changes. Study period was for 2 months. These are my inclusion and exclusion criteria. Demographic and clinical data were collected and cognitive function was assessed using MoCA questionnaire. Now, what is this MoCA? Montreal Cognitive Assessment was developed by Dr. C.R. Nasruddin in 1995 in Montreal, Canada for the detection of mild cognitive impairment. Today, it has been used as a highly validated tool with a sensitivity of 90% and specificity of 87% used in clinical research all over the world. We completed the training and obtained certificate for administering and interpreting MoCA. This is how the MoCA questionnaire, these are the various domains tested in MoCA. It is printed on one side of an A4 size paper. A score of more than or equal to 26 is considered as normal. However, these scores can vary according to the race and ethnicity. So we took another study based on Milani et al. And we took these criteria, 19 and 23 also in our study. These cutoffs were also applied in our study. There are many versions of MoCA available. We used the Malayalam version, which was validated in 2015 by Sri Chitra Tirunal Institute for Medical Science and Technology, Trivandrum. You can see visuospatial function of a participant being assessed here. He's asked to draw for trail making, copying a cube and drawing a clock. Now he's copying a cube correctly. Now he's asked to draw a clock with the correct contour, with the correct all the numbers and hands of the clock depicting a given time to him. This is another participant. She has completed trail making, but it is incorrectly done. She has tried to copy a cube, but it is also incorrect. And she is not able to complete a clock drawing. Similarly, all the other domains were tested. The collected data was statistical analysis were done. We had 25 NTG patients and 25 age, gender, and education status matched normal participants. 56% of them were males. 56% were in the age group of more than 60 years. 32% had an education up to higher secondary school certificate. These are the various clinical risk factors I looked for. The prevalence of cognitive impairment was 88% in the normal tension glaucoma and 20% in the control group. Even after stratification for race and ethnicity based on the other study, the prevalence was still 72% in normal tension glaucoma and 12% in control group. Among the 25 NTG patients, we had 14 with moderate cognitive impairment, 8 with mild cognitive impairment, and only 3 had no cognitive impairment. Among the various domains affected, visuospatial executive functions, delayed recall of memory, and memory index score were found to be significantly lower in normal tension glaucoma as compared to the control group. There was also a negative correlation obtained between IOP before treatment and the MoCA score. There are very few reports from all over the world using MoCA for cognition assessment, that too in NTG, and very, very few from India. We had got a study by Mulani et al. Where they used a telephonic version of MoCA, and they found that NTG status was associated with a higher prevalence of impaired cognition than high tension glaucoma. There is another similar study to ours that was by Bullitt et al. Their findings were also similar to ours, but they used mini mental status examination scores. However, studies have shown that MoCA has got a very high specificity and it is more sensitive as compared to MMSE. In our study, there was a statistically significant difference in visuospatial and executive functions. These are the functions of the frontal lobe. Trail making was found to be difficult for all NTG patients. Only 16% of them were able to copy a cube. Clock drawing could be completed by 48%. Also, delayed recall memory. Memory was another domain affected. Memory index score. These were also lower in the MIS group, in the NTG group. Now, why is this so important practically? We cannot rely upon intraocular pressure for the progression, for assessing the progression. In case of NTG, we have to depend upon visual field. But can we really do that? Because studies have shown that a mild cognitive impairment in glaucoma is associated with increased false negative reports that can lead to an overestimation of mean values. So are we looking at a real true progression, or are we incorrectly treating a false worsening of the condition? We need to have an optic nerve assessment and evaluation mainly, and we have to depend on that. We can also, keeping the vascular theory of NTG in mind, we can assess the vessel density using newer modalities like MoCA, the OCT angiography for the same. So are we looking at eye being an early biomarker of dementia or neurodegenerative disorder? Our study highlights the importance of cognitive impairment in the screening of NTG. These are the limitations of my study. To conclude, cognitive impairment was found to be significantly associated in NTG, specifically impacting visuospatial and memory domains. These are my references. Thank you. Yes. Yes, madam. Yes, madam. Bromonidine is supposed to be neuroprotective, so we hadn't we had 25 patients only, and all of them were on drugs that was on prostaglandin analogs. Only 10 were having prostaglandin analogs along with bromonidine, but we couldn't get a statistically significant result with the MoCA score. That is why I didn't include that in the presentation. Yes, madam. Okay, madam. Yes, madam. Have a yes, madam. Yes, madam. Yes, madam. Thank you, madam.
I'd also say well done. My sort of issue was in the original case selection and the controls. Probably it's not very clear in the presentation, but how did you assess the capability of your patient group initially to be able to do this MOCA? Because your educational standards were pretty
Yes, sir.
low.
32% were up to higher secondary school. 28% had up to 10th standard. 26 actually had up to graduation, and 12% were actually in a professional degree. But 3 out of 25 in both the groups had only primary education. For that, in MOCA, we add a +1 score. If they don't have 12 years of education, we add a +1 to the total score. However, it is not being there is no normative data for Indian population. These are all for Caucasian population. We need Indian studies to have to compare that correctly to our socio-economic status and education levels, sir.
I think it's a very good piece of work,
Thank
and
you,
I
sir.
think you should work towards sort of getting it published as well.
Thank you, sir.
Okay.
Thank you, sir.
Good afternoon, everyone. The topic is about the comparison of conventional trabeculectomy versus trabeculectomy with deep sclerectomy. No financial interest. Trabeculectomy has become the most commonly performed surgery for the reduction of intraocular pressure, and various technical modifications have been developed in this procedure. One among this is a trabeculectomy with deep sclerectomy, which claims to eliminate or minimize the complications of classical trabeculectomy. Aim of our study was to compare the efficacy of conventional trabeculectomy and trabeculectomy with deep sclerectomy. So this was a retrospective study conducted between January 2018 to June 2022 on 60 eyes of 60 patients with medically uncontrolled glaucoma. Informed consent was taken. The inclusion criteria includes patients with glaucoma with uncontrolled IOP with maximum tolerated medical therapy, and exclusion criteria include patients who underwent combined glaucoma and cataract surgery in a single sitting. So the complete ophthalmic evaluation was done, which includes a best corrected visual acuity, slit lamp examination, applanation tonometry, gonioscopy, fundus examination, and HFA. And the group was divided into 2 groups of 30 patients each. While the group 2 underwent conventional trabeculectomy, group 1 underwent trabeculectomy with deep sclerectomy, in which after placing the corneal traction suture, the conjunctival peritomy done, tenons exposed, careful hemostasis done, 0.2% MMC sock sponge is applied subconjunctivally and removed after 2 minutes, followed by a thorough wash. A superficial scleral flap 1/3 of thickness, 4 × 4 mm, hinged at the limbus was dissected 1 mm into the clear cornea. Then a 3 × 2 mm flap of deep sclera was dissected under the superficial scleral flap, extending up to the limbus and cut with Vanus. Anterior chamber is then entered under the superficial scleral flap, and trabeculectomy is done as in the conventional trab method, followed by a peripheral iridotomy, superficial scleral flap repositioning done. Postoperatively, all the patients were given with prednisolone acetate 1% eye drops in tapering doses for 8 weeks, moxifloxacin 0.5% eye drops 4 times a day for 1 week, and atropine 1% eye drops in tapering doses for 4 weeks. And the follow-up data was collected at day 1, 1 week, 1 month, 3 months, 6 and 12 months postoperatively. Complete success was defined as postoperative IOP of 6 to 16, between 6 to 16 millimeter of mercury with no anti-glaucoma medications, and qualified success was defined as postoperative intraocular pressure less than or equal to 16 with anti-glaucoma medications. These are the characteristics of the patients in the deep sclerectomy group and the TRAP group. The mean age was 58.03 in group 1 and 57.2 in the group 2. Male is to female ratio was 18 is to 12 in group 1 and 20 is to 10 in group 2. Mean pre-op IOP was 29.77 in group 1 and 32.23 in group 2. Mean duration of glaucoma was 3.83 years in group 1 and 3.63 years in group 2. So this shows the change of intraocular pressure at different time points in both the groups. So it can be seen that there was a significant IOP reduction after surgery in both the groups throughout the entire follow-up period. Regarding the post-operative complications, 7 eyes out of total 30 eyes in group 1 had post-operative complications. That is 23.3% in group 1 had post-operative complications. Among that, 6 eyes developed high IOP, 1 eye developed wound leak. And in group 2, 5 eyes among the total 30 eyes develop post-operative complication, which includes 3 eyes having high IOP, 1 eye having wound leak, and 1 eye developed NVI. Regarding the post-operative surgical interventions, 7 eyes in the group 1 needed post-operative surgical interventions to control intraocular pressure, which includes 5 underwent bleb needling, 1 eye underwent resuturing, and 1 underwent diode CPC. And 4 eyes among the group 2 needed post-op surgical interventions to control IOP, which includes 3 underwent bleb needling and 1 underwent resuturing. Regarding the success and failure rates, 63.3% had complete success rate, 20% had qualified success rate, and 16.7% had failure rates in both the groups. Regarding the AGM usage post-surgery, it was seen that 10 patients in the group 1 needed more AGM compared to the group 2. According to our study, the intraocular pressure lowering effect is comparable between the two groups. No significant differences in the absolute or qualified success rates noted. Complication rate and the need for multiple AGM post-surgery was found to be more in the deep sclerectomy group. Complications noted were more having transitory hypertony, then noted was shallow or flat anterior chamber, and then comes the bleb-related complications. No serious complications like severe hyphema, malignant glaucoma, or any persistent choroidal detachment noted. Our study shows that the rate of complication is more in the deep sclerectomy group compared to the TRAP group, which was statistically significant. So it can be concluded that both trabeculectomy with and without deep sclerectomy seems to be a valid and safe alternative to lower the intraocular pressure. These are my references. Thank you.
Good presentation. But I have a little bit of a worry about the technique.
Okay.
You did show us a video.
Yeah, that was only the deep sclerectomy step, not the entire trap because of time constraints.
Agree. But what's the point in putting in a hole if you are doing a deep sclerectomy?
So I didn't get you.
Say, why are you doing a trabeculectomy on top of a deep sclerectomy is my question.
This was actually an additional step, deep sclerectomy. Like after
The
the
question is, which one is the addition? Are you adding the deep sclerectomy or are you adding the trabeculectomy?
deep sclerectomy is added to the conventional trap method. Like the trabeculectomy is already there. Then addition to that, a
No,
deep sclerectomy.
trabeculectomy was not there.
No, I didn't show
Yeah,
actually.
thank you.
Like
And you are doing a deep sclerectomy.
yes, sir.
Fine. Which again is not classical deep sclerectomy, but that's fine. Yeah, Mike.
This was actually penetrating type, not the.
Yeah, so you see, once you penetrate, you lose the advantage of the deep sclerectomy, and you're just adding on something for as your study shows for nothing and getting a few more complications.
Yes, sir.
Okay?
So we are actually
You either
finding
believe
whether
in one thing or believe in the other thing and just go for it.
we were actually trying whether we get any like added advantage with the deep
You got
sclerectomy.
the complications.
Yes. It was found to be. Yes, ma'am. Oh, sorry. Yes. Or tab. Me is lost. Okay. Okay.
Yes, you presented well, everything's fine, but there's that little flaw at the very beginning. It's not your fault.
Yes. Sir.
Obviously, whoever's doing the
Okay, sir.
we all learn.
Yes, sir.
We all learn. And I do a lot of these writings.
Okay. Okay. Thank you, sir.
Concludes everything, I think. Yeah, that concludes the session. Thank you very much, all of you, for presenting. Very nice presentations. I think quality of the presentations were very good. Each time I come to Kerala state meeting, I'm impressed by the quality. Yes, and you're standing up there, you're talking well. The only criticism I would say is you can slow down a little. English doesn't have to be. You don't have to take a deep breath and keep going. Breathe in between. Okay, so that is one little bit of advice that I